Good morning. I'd like to thank Dr. Tinku Bali for this opportunity. I'll be speaking on practical management of retinal vein occlusions. So the first thing is to look for when we see a patient with vein occlusion, the first thing is to start looking for systemic comorbidities. Yeah, that's enough. Thanks. So look for systemic comorbidities. That is the most important thing. Hypertension, diabetes, dyslipidemia, and tobacco use. In younger patients, it's usually inflammation, homocystinemia, blood dyscrasias, thrombophilia like antiphospholipid antibody syndrome, and very important, which we do not ask, is medication, oral contraceptive pills or sildenafil. Now, when we are looking at a patient with RVO, very important to look for glaucoma. This is the most common ocular comorbidity. Look at the disc very carefully. Even the other eye. Sometimes it's the other eye which is advanced glaucomatous disc. And once we know there is glaucoma, then avoid intravitreal steroid injections. And the glaucoma specialist should avoid using glaucoma medication, which can increase the risk of recurrent cystoid macular edema. When we see a case of retinal vein occlusion, it can be based on its location, central hemiretinal, which is either superior or inferior, and branch retinal vein occlusion. The CRVO and HRVO can be ischemic or non-ischemic. Because of the large extent of involvement, these lead to serious ischemic complications. Branch vein occlusion can be a major vein or a macular branch vein occlusion. This is one of the commonest disease, non-ischemic CRVO, where the macular edema is milder, the presenting vision is relatively good, and they generally recover good vision with injections, though macular edema is often recurrent and requires several injections. On the other hand, the ischemic variety comes with very drastic vision loss, extensive hemorrhages, severe macular edema, or even if the macular edema is not severe, the vision is disproportionately poor because of ischemia. And even after treatment, the vision remains poor because of macular ischemia. More importantly, these patients, the hemiretinal vein occlusion is superior or inferior. Two quadrants are involved. The CRVO and HRVO, they require vigilance for neovascularization on the iris and neovascular glaucoma. So very careful examination of the undilated iris, angle with gonioscopy is very important. And this used to be happening in the first 3 to 6 months earlier, called 100-day glaucoma. But nowadays it doesn't happen initially because we start using anti-VEGF injections for the edema. So now we see these patients coming after 1.5 years, 2 years of onset, when the anti-VEGF has stopped. When we give up the injections, either patient gives up or we give up, or there is no more edema, then they come with neovascular glaucoma. And even non-ischemic cases of CRVO, HRVO can down the line progress to ischemic type. So they are not out of danger. Branch retinal vein occlusion can be one of the 4 major veins. The nasal BRVOs remain asymptomatic because macula is not involved, but they can lead to proliferative complications. So they need annual checkups. Now initial complications are macular, which can be any of these. So the most common is, of course, the macular edema, which responds to anti-VEGF and steroid injections, but also macular hemorrhage. In chronic macular edema, they start developing epiretinal membrane, and even with treatment, they can go on and develop a macular hole with poor prognosis. They can present like this with an ERM and holes. And another problem is the hard exudates which accumulate when patient is not treated in the right at the onset. And these hard exudates, once they come, generally they cause permanent vision loss. So that is why, and most importantly also the cause is poor systemic control, uncontrolled diabetes or lipids, dyslipidemia. They need more intensive intravitreal injections, higher number of injections with greater frequency for resolution. And even with resolution, they may leave behind permanent vision deterioration. Most important is systemic control. And prevention of these exudates is important by timely treatment. However, they do resolve, as I have shown in this picture here. When you neglect, it goes from 1 to 2, but after treatment, you can have resolution. Other problem is ischemia. There may be no edema, but you can see the hyperreflectivity on the OCT showing ischemia. So vision is not good, but there is no edema. BRVO can also present down the line after few months with the silent new vessels on the iris, not on the iris, the retina or the disc, and silent vitreous hemorrhages or massive vitreous hemorrhages. So every BRVO needs annual checkup even if vision is good. That has to be emphasized. And timely treatment, for example, NVD seen in this patient, we can do a scatter laser in time and prevent blindness. So annual evaluation has to be emphasized, lifetime annual evaluation. These are patients who did not have any symptoms, but they came for their annual checkups. And you can see the vitreous hemorrhages, NVD, NVE, and timely scatter laser was done. And this is how it regresses. The NVD has regressed with. Often we may have to extend the laser not only to the involved quadrant, but also adjacent quadrants. And many times if the ischemia is severe enough, we have to do a complete pan-retinal photocoagulation even in a BRVO. They can come like this with their end-stage disease, tractional retinal detachment. So surgery followed by good scatter laser during surgery itself. Macular branch vein occlusion is a localized affection, so there is no proliferative complications, but the macular edema can be very recurrent or resistant to treatment. Imaging in retinal vein occlusion, multimodal imaging is required with all these modalities. The OCT shows us not only edema but also ischemia, the hyperreflectivity that you see. Photographs are very important for capturing exudates, hemorrhages, which are not captured by the OCT that well. If you see this patient over 5 years of treatment, OCT has remained the same. So patient would think that there is no improvement with treatment. But if you see the exudates have resolved. So the treatment has helped the patient, and that is very important to document. OCT angio has become very important to see macular ischemia, or even it picks up new vessels on the disc or elsewhere which was not expected. However, OCT angio cannot show us the leakage which we need to see for doing laser, macular laser. Now, this patient was being treated with a lot of injections outside, but diagnosis was not clear, whether it is a succinate diabetic maculopathy or a BRVO or a macroaneurysm. So fluorescein gave us a diagnosis. There was a quadrantic hypoperfusion superior with collaterals showing a superotemporal BRVO. So we now know where to laser for the exudates. Octa could not show this because the patient of motion artifacts. And Octa also becomes relatively useless when the media is opaque. Fluorescence still gives us some images. So this is where to do the laser for the exudates. Again, patient with exudates, not sure what's going on, and angiogram shows us where is the leakage, inferotemporal BRVO with leakage. So that is where the grid has to be done. It also throws up new vessels, which we may or may not have expected in an opaque media, and also shows new vessels on the iris with leakage. So fluorescein has advantages over OCT angiography in patients with opaque media especially. Treatment, serial anti-VEGF injections are the first line treatment. There's no timer that I see here. Okay, 20 seconds. Is it showing somewhere? Okay. Okay, not to us here, okay. So anti-VEGF injections are the first line of treatment and have good response. These are the various anti-VEGF injections and steroids. Steroids are second line because of their major side effects. Dex implant can migrate into the anterior chamber if there is a large opening as a scleral fixated IOL. As you see in the picture on the second from right, that's my own patient, scleral fixated IOL, and it can cause a corneal decompensation with very high IOP. This we were able to remove in an emergency and the patient was doing well. So when do we use steroids? Only when there is inadequate response to anti-VEGF or where anti-VEGF are contraindicated, absolutely in pregnancy contraindicated, or recent cardiovascular events, severe renal dysfunction, or where there is some traction which can get worse with neovascularization. Laser is recommended only for branch retinal vein occlusion after doing an angiogram. This can give some long-term benefit and reduce the number of injections required with time. However, it is not recommended for CRVO or related CME. There we only need a pan-retinal photocoagulation for new vessels on the iris, angle, or elsewhere. So follow-up for any case of RVO every 6 to 12 months is mandatory with intraocular pressure, undilated slit lamp exam, gonioscopy for angle new vessels, and very, very important, fellow eye because many times the other eye also has a vein occlusion which is sitting silent but with proliferative complications, which will lead to blindness. If there is a disproportionate vision loss with CRVO, look for this kind of whitening in the center, which is a cilioretinal artery occlusion. This reduces the prognosis because macula becomes ischemic. So even with anti-VEGF injections, the visual prognosis is poor. And this is the last slide. RVO in the young behaves very differently. It is often idiopathic, though there could be blood dyscrasias or medicine use. Generally, the vision is good at presentation also, and the macular edema is mild, and usually one anti-VEGF is enough, one injection is enough. They do not require repeated injections. Good visual prognosis. Thank you.
Thank you, Dr. Mallika. So I invite questions from the audience, if any. What you very well highlighted was the importance of follow-up in these patients. So many years down the line, there'll be a lot of sequelae. These patients generally come back with vitreous hemorrhage if they are not tended to. So please follow up the patients and do emphasize that to the patients of any vein occlusion.
So we move on to our next talk.
One question, I think.
Just wanted to ask you, when do you plan a PRP in a case of CRVO? Only after you've seen the new vessels on the iris, or should you do it when the patient first comes to you?
No, not first comes to you, because the CVO study, which was done several years back, has shown that it should be done only when new vessels are seen. In fact, they showed that if it is done before NVI develops, then it in fact does not do any benefit and may not prevent NVI for some reason. And then you are reducing the field of the patient further with PRP. So I think there should be a definite indication in terms of NVD, NVE or NVI.
So you just keep these patients on follow-up unless and until you see something?
Yes.
Thank you.
Thank you.
Thank you, ma'am.
Do you routinely recommend testing homocysteine levels in all patients of venous occlusion? And if you find that homocysteine levels are raised, what additional thing you need to do?
I do advise for all patients, even elderly patients, because many of them do have on the higher side. What we do start is homocheck, which is a combination of various vitamin B complexes, which increases the which reduces the homocysteine level. Plus, there is a diet schedule which is low meat, low methionine, high in fruits and vegetables, which is advised to them, and more of exercise. So there is that diet, if you read up, there is a diet schedule which you can give them, and then their homocysteine at 6 months comes down, you can stop it. It does increase the risk of, because in some patients that is the only risk factor which comes out positive.
Thank you, ma'am.